thanks all for coming tonight. It's so good to see so many familiar faces out here, and a lot of your practices I've been to visit, and you've all made me feel extremely welcome. And tonight's lecture is on the pruritic dog and atopic dermatitis. And so most cases of pruritus in the dogs are caused by allergies, and flea allergies are probably the most common type of allergy that you'll see in practice, followed by atopic dermatitis, and then less commonly food allergies. Infections are common secondary to those allergies, and infections themselves can be extremely pruritic. Ectoparasites such as scabies, I think, are probably commonly missed, and we'll talk a little bit more about that in a little bit. And then disorders of cornification, seborrhea, can often be pruritic as well. History is probably the thing that I spend the most time in the appointment talking about. I generally take 15 to 20 minutes with a client discussing the history. And when I was in general practice, I was working in the US, and I was working for a big company that only allowed us 4 minutes for an appointment, and then we'd move on to the next patient. And so once people knew that I had an interest in dermatology, I used to actually schedule a dermatology appointment and make that a 30-minute appointment so I could take my time to ask the history, because I do think that's very important. Age of onset is really important. If the dog is less than 12 months of age or older than 3 years of age, then I'm going to start thinking food allergies over something like atopic dermatitis. Atopic dogs tend to present between 12 months of age and 3 years of age, unless there's been a significant geographical change. So for instance, they've moved from Sydney to Brisbane, or in my case, my dog moved from Sydney to Davis, California, and at 14 years of age became an atopic dog, because that's a significant enough geographical move. Seasonality, I tend to forget to ask that question these days, because what I'm finding that is a lot of our atopics are year round, so whether something's seasonal or not does not really affect my decisions. Previous or present prescriptions, corticosteroids are really the drug that I'm most interested there. Is it corticosteroid responsive? If yes, then we're likely dealing with atopic dermatitis or flea allergy. Food allergies don't tend to be very corticosteroid responsive at all, and neither does scabies. The diet is also very important. What is the dog currently eating? What has it eaten before? Because if I'm going to food trial it, I really want to choose a novel protein and carbohydrate, so something that the dog hasn't been exposed to. Flea control. I really grill the owners on this one, because if I just asked an owner flat out, is your dog on flea control? The answer is always yes. They're lying to you. The dog's probably not on flea control. And so I ask specifically which one and where they apply it. And the amount of people that tell me frontline goes in the mouth is phenomenal. And if that's actually where it's going, then we have a big problem in the veterinary industry. The only two flea preventatives that I recommend using are Comfortis and Capstar. Obviously, we need to use our topical preventatives for tick prevention, but for a flea allergic dog, Comfortis and Capstar are the only two that I would recommend. I think these days dogs are being bathed very frequently, or they're swimming frequently, and despite what the companies will tell us, hopefully we're not being sponsored by any of them tonight, they do wash off with bathing or with water application. Travel history, not so important in Australia. In the US, I did ask about travel history when patients came in, because we did see a little bit of leishmania, and so I was interested in travel history for those purposes. Other pets or people affected, that's a really important question. I had 2 cats come in the other day. One cat had recently been to Sydney Uni because it was blocked, and they'd clipped its neck to take blood from the jugular, and it developed a skin lesion. 2 weeks later, the in-contact cat developed skin lesions on its head. The owner comes in, she's got ringworm all up her arms, and so I really didn't need a fungal culture to tell me what was going on there. It was fairly evident. And then systemic clinical signs, I think, is important as well. Dogs with food allergies, about 50% of them will have diarrhoea, we think, or soft stool, or increased mucus in the stool. And so for food, if I'm suspecting a food allergy, I do ask some questions about the gastrointestinal signs. What are the lesions? So these are papules. Papules are the initial lesion that we'll see in an inflammatory response, and papules don't always indicate infection. If you were to take a sample from those papules early, you'd probably see a lot of eosinophils, not a lot of neutrophils or cocci. And then we have epidermal collarettes. These are very classical lesions that are associated with staphylococcus, and we've got our central area of erythema and then the periphery of crusting. Close up of those lesions there. Where are the lesions is the other important thing in dermatology, so tail, head and ventral abdomen flea allergy, and I think sometimes we forget that the ventral abdomen can be a real prime site for dogs with flea allergies, particularly around the umbilicus. And there was a veterinarian called Peter Erkey, who was very famous in the dermatology world. He's recently passed away, but the area around the umbilicus is nicknamed the Erkey spot because he associated, when he saw erythema in that area, it was strongly associated with a flea allergy. And then margins of the ears and elbows, think scabies. Scabies really likes thin-skinned, sparsely haired areas. And then atopic dermatitis and food allergies look exactly the same: face, feet, ears. So this is a dog with flea allergies. I never get to see them looking quite this beautiful. I think this is what you guys maybe get to see in general practice, except for when I was in California. 50% of the patients that came in to see me look like that. In California, the system was quite weird. When I see cases here, it's because you've sent them to me. When I see cases in California, it's because the owners brought themselves. And so a lot of the things I was seeing was exactly like this. And then this is the Erkey spot. It's quite subtle. You've just got some mild erythema and papular eruption around the umbilicus there. And then this is a dog with scabies, really classical distribution around the ears and face. And then around the backs of the elbows too. And our lovely scabies mite there. And how often you find scabies mites, depending on who you speak to, your answer will be different. Some textbooks say 30% of the time, others say 50% of the time, others say 80% of the time. I think I average maybe 50% of the time. What I've found is the best way to collect samples for scabies is to put the oil on the area that you want to scrape and then use the scalpel blade to scrape all of that oil onto your slide. And I think that allows you to cover a greater area and increases your likelihood of collecting the scabies mites. My personal protocol is any dog that's above a 7 out of 10 pruritic when it comes to see me gets in a caricidal trial regardless of whether I think it has scabies or not. And so what I use for my caricidal trials is Revolution. I use it every 2 weeks for 3 doses. Zoetis will tell you that you can use it once a month and that will be effective for scabies. I don't think it breaks the life cycle enough. I think you do need to do it every 2 weeks, 3 times. I use that in preference to ivermectin. I think it's just easier. And then I don't have to calculate out a dose, and I hate math. And then this is a dog that has atopic dermatitis, and I could easily buy that dog has scabies as well. And so if that was a dog coming into me, it would definitely be getting in a caricidal trial. Diagnostic procedures, every dog that comes in to see me and every dog that comes in to see you guys for dermatology should have cytology and skin scrapings done. I think they're really easy procedures to perform, and really it's our minimum database for the same as a dog that has been vomiting or having some other sort of internal medicine problem. They want blood work and a urinalysis. That's their information. Skin scraping and cytology is our information. And skin scrapings, I'll tell you how I do those in just a little bit when the slide comes up, because I do them slightly differently. With cytology, if the lesion is exudative, then a direct impression smear is what I would do. If it's a drier lesion or if it's on the foot, then I really like to use tape preps, and the type of tape that you use is actually important because it makes a difference to the visibility of the organisms under the microscope. Just plain Scotch tape, not the frosted one, and it has to be the Scotch brand. I have tried to use other tapes and I'm not as happy with the results. And then skin biopsy. I generally don't skin biopsy pruritic dogs unless they're over about 10 years of age, because cutaneous lymphoma is something that can be extremely pruritic, and it can look very, very similar to a dog with a pyoderma or to a dog with atopic dermatitis. And then trial therapy for ectoparasites. As I said, for flea allergies, I recommend using Comfortis, and I dose that every 3 weeks. A lot of dermatologists dose it every 2 weeks. Spinosad still has 99.1% efficacy at the 3-week mark. That's good enough for me. I don't think we need to be dosing it every 2 weeks. And then Revolution for scabies. For microorganisms, if it looks like a pyoderma to you, and you're not seeing any organisms on your cytology, then you can treat it like a pyoderma, because sometimes bacteria can be difficult to see under the microscope. Versus Malassezia, if you think it looks yeasty and you've taken your cytology and you're not seeing any evidence of yeast, it's not there. It's easy to find. And so I never do treatment trials for Malassezia. Elimination diet trials. I prefer the home-cooked elimination diet trials, so novel protein carbohydrate. Protein sources can be kangaroo, venison, rabbit, horse, donkey, whichever of those proteins are most easily accessible. If you guys email me, I actually called around to lots of butchers in Sydney and got a list of places that stock those proteins, so I'm happy to forward that on to you for your clients. And then as far as carbohydrate sources go, sweet potato or pumpkin are the 2 main ones that I use. The reason I prefer a home-cooked diet over the commercially prepared ZD or hypoallergenic is because, as we know, ZD is made from hydrolyzed chicken and hypoallergenic is from hydrolyzed soy. And they've actually done studies where they fed dogs that were confirmed allergic to chicken ZD and dogs that were confirmed allergic to soy hypoallergenic. And 10% of dogs in each of those groups were still pruritic. So at the end of that trial, we don't know if the dog doesn't have a food allergy or if it's in that 10% that is pruritic because it won't stabilise on those diet choices. It's not that I don't use the commercially prepared diets, because if the client tells me they're not going to do a home cooked diet, well then that's our next best option. But if they're willing to home cook, then that is definitely ideal. I do miss being in America sometimes, because in America we have commercially prepared novel protein carbohydrates. So Royal Canin makes a rabbit and potato, they make a venison and potato, and IAMS makes a kangaroo and oats, and so it makes doing elimination diet trials very easy. And then intradermal testing. The only point to doing intradermal testing or IgE serology is if the client wants to have the animal desensitised. Otherwise, it's an academic exercise. They can't avoid these things in the environment, so there's no point spending their money unless they're interested in investing in desensitisation. As far as which of those two tests I do, I usually recommend doing both. And the reason for that is they're testing slightly different aspects of the immune system. So the intradermal test tests the IgE that's bound to mast cells in the skin versus the serology, which tests circulating IgE. So you do get a more comprehensive profile. If you guys are sending me cases, I'm happy for you to run the serology as long as you send me the results, and I'm happy to do the intradermal skin testing. When they've done studies to show whether the success of desensitisation is different off intradermal skin testing or the serology, the results are actually the same. So whether you base your desensitisation off a skin test or a blood test, it doesn't really matter. But no one's done a study where they've combined a skin test and a blood test to see what the success of that is. And I think I have better results because I do run the both tests in conjunction. And this is a really nice little table that summarises the 3 different types of allergies, the age that we typically see those allergies, and flea allergies and food allergies once again are any age versus atopic dermatitis, which is much more restricted, and then the areas that we typically see lesions in. And when I've put maybe for the food allergy here, I think early in a food allergy they can be quite responsive to steroids. So the dogs that you get that are 6 months old coming in with pruritus that initially responded to steroids and then after a month don't tend to do so well but do very well on a food trial. I think early in a food allergy you might get them with steroids, but long term it won't last. So now we'll talk a little bit more about atopic dermatitis, and it's an allergic or inappropriate reaction to environmental allergens or antigens. And previously we thought that the respiratory route was the most important route of exposure, but now we know the percutaneous route is probably more important than the respiratory. And it does seem to be mediated by IgE antibodies, and what we've identified now is that there is a barrier dysfunction in these dogs that have atopic dermatitis, and if you do any reading in the human literature, it's all about the barrier dysfunction with humans, and we'll cover that in a bit more detail. So the allergens interact with Langerhans cells, which are antigen-presenting cells that then present to T cells and B lymphocytes to produce IgE. IgE then binds to the mast cells and causes degranulation. And inflammatory cytokines are also released, and I'm not going to go into that more now because I have a video later, but there are new drugs that will be released onto the market in Australia shortly that really focus on those cytokines, so we'll watch the video on that. In general, dogs are around 1.5 years of age at UC Davis when they presented with atopic dermatitis, and the breeds that we saw most commonly were Retrievers, Dalmatians, Shar-Peis. I see a lot of Bulldogs here. I've seen a lot of German Shepherds here so far, and also actually quite a few Great Danes, and plenty of cats. For whatever reason, Sydney seems to have a lot of atopic cats, which incidentally are not my favourite patients. And then there doesn't seem to be any sex predilection. Before I came down to have a drink and a bite to eat with you guys, I was seeing a cat for a demergency. Itchy ears. All right, so clinical signs in dogs, they're generally pruritic, have erythema, small papules, and we talked about the distribution before. Got a very erythematous foot there with some salivary staining, and when you see that kind of brown discoloration around the claw there, it's not usually salivary staining, that's usually malassezia, and that can be why they're so pruritic on their feet. And so I'll usually scrape that and then smear it onto a slide just to confirm my diagnosis. If I see a foot that looks like that, that's also getting a scraping, because I could easily buy that that's Demodex as well as an itchy foot from atopic dermatitis. And then Cocker Spaniel. And then this was the atopic dog we saw before that we could easily buy scabies for, with alopecia, erythema, some crusting. And then things can be fairly mild as well. So this dog just has mild erythema around the face, and this dog was a 10 out of 10 pruritic. So sometimes a client will come in and I always ask them on a 1 to 10 scale, because when I'm following up with them, that's the best thing they can give me so that I can guide my therapy. And so dogs don't have to induce a lot of self-trauma to be extremely pruritic. And so the client's perception is really the most important thing, unless it's really wrong. So I've had some clients come in and the dog has literally been tearing itself to pieces, and I say, on a 1 to 10 scale, what level are we? And they say 0. And I say, do you understand the scale? And they do, but apparently it's still a 0. So in those cases, we need to do a little bit of correction. And then we've got some lovely epidermal collarettes on the belly there, erythema, and a little bit of scaling too. And then this was a dog that had both food allergies and environmental allergies, a Labrador. That looks really yeasty to me, but there was no malassezia on that dog's body at all. That's all pyoderma. And so I used to look at dogs that had this hyperpigmentation, mild erythema, alopecia and lichenification, and just think it's always malassezia. But I think 50% of the time it's bacteria, 50% of the time it's malassezia. And so that's why cytology is so important. Mild erythema and alopecia. And then it can be more dramatic too. I'll see this a lot in Westies. This one I put up here, it's not funny because there's something wrong with the dog, and that's never funny. But when you look at this, it's not allergies. This is actually a specific condition of the standard poodle. Does anyone know what this is? No, good thought though. It's just affecting the eyes, particularly the medial canthus, and it has blepharitis. It's called medial canthal blepharitis of the standard poodle. And the reason it's so funny is because this dog came to me for allergies, and I was like, that's not allergies, because I don't know whether dogs with allergies do get conjunctivitis. There's not a lot of studies on that at all, and no literature proving or denying that. And the dog had no other signs whatsoever. So I took it down to the ophthalmologist at UC Davis, who is David Maggs, a fellow Australian, and he says, oh, I know exactly what that is. That's medial canthal blepharitis of the standard poodle. I burst out laughing because I thought he was joking. And then he opens up his textbook and there's actually a little chapter on it, and it responds really well to steroids. And so the reason I show this to you, so if you see it, you know a little bit more about it than me. Atopy in cats, we don't have as much information on, and I think in general cats are frustrating patients, but particularly atopic cats. We think the etiology is the same, signalment, who knows. Cats tend to get really pruritic around their face and head, really with the food allergy, but also with atopic dermatitis. We do see miliary dermatitis in atopic cats. When I see just miliary dermatitis, I'm really thinking flea allergies as opposed to atopic dermatitis. Eosinophilic granuloma complex could be flea allergy, could be food allergy or atopic dermatitis, and then self-induced alopecia as well. So this is a cat that had head and neck pruritus, and I've actually had a cat that come into me once, and the cat was so pruritic that when the owner lifted it out of its box, the zygomatic arch was exposed, because that's how pruritic it had been on its face. So cats can be very traumatic to themselves. And then some lesions around the face. And if I was to see lesions like this around an eye in a cat, I would also be scraping that cat, because I've seen Dermatitis look very similar, or Dermatitis look very similar to that. And this cat, I thought had dermatophytes when it came in, but I fungal cultured it and couldn't grow anything. And the cat was extremely pruritic around its face, and purely its face. And this cat had a food allergy as well as atopic dermatitis. And as far as how much overlap there is between those two conditions, in dogs, we think about 30% of dogs that have atopic dermatitis will have a concurrent food allergy. So it is very important to do food trials in all our patients we suspect of atopic dermatitis. Cats, we don't have so much of an idea. But in cats, when you're reading the current literature, it's no longer called atopic dermatitis. It's called non-flea, non-food dermatitis. Yep, that's what it's called. I didn't name it, and I won't be calling it that. And so then we have some self-induced alopecia here too. I think that was too many dermatologists around after 5 bottles of wine that came up with that one. And then cats don't tend to get a lot of pedal pruritus, but we certainly do see that versus dogs, where itchy feet seems to be very common in dogs with allergies. Secondary infections are very common, and unless we're managing the secondary infections as well as the underlying allergy, we won't see significant clinical improvement. Something that I get asked a lot is, if a dog has a pyoderma and is pruritic, should I give it steroids? Yes, you should, because if you don't, obviously you treat the infection too, but if you don't give the dog steroids, then the dog's pruritus is not going to decrease, and the owner's going to be frustrated with you, and she's going to go to another veterinarian. You need to manage the pruritus as well as the infection, and the reason that people say don't give steroids when a dog has a pyoderma is because it inhibits neutrophil chemotaxis. I don't think it does it to such a degree that we can't give steroids along with antibiotics and resolve the infection. If it was a really deep pyoderma, I might be a bit cautious with my steroids, but a superficial pyoderma, it's not going to bother me to use steroids whatsoever. I probably like steroids even more than other dermatologists in Sydney. And then these are some more epidermal collarettes here, typically associated with staph. And then this is a dog that gets presented to me fairly frequently, and the owners present it for dandruff. It's very rare for a dog to have dandruff. What that is, it's a pyoderma. It's always a pyoderma until proven otherwise. And so if you were to clip that dog, there's probably going to be papules, pustules and collarettes that you would see quite easily. And when you look closely at this dog, you can see that it does have a little collarette on the surface of the skin there. So any dog that I see like that, I do cytology, do my scrapings, but I'll treat it with 4 weeks of antibiotics. And then collarettes can be very, very pigmented as well, or they can be hypopigmented. So there's a little bit of a spectrum of lesions that can present. Malassezia, also very common, and typically likes to go in folds and feet, into trigonous areas. And then these are the claws that we spoke about before, so really important to scrape those claws and get some cytology on there. And then that's typically the type of skin that we associate with malassezia, hyperpigmented, lichenified. And malassezia in cats I don't see very often. Maybe in Devon Rex cats or Sphinx cats I do see it, but in other types of cats, if there was generalised malassezia, I would be looking for underlying systemic disease. It's not something we typically associate with atopic dermatitis. So in a cat that had generalised malassezia, I would be performing a CBC, chemistry and urinalysis, and probably a feline leukemia and AIDS panel as well. Typically when I've had cats with generalised malassezia, it's been in diabetic cats. And then as we discussed before, we can diagnose that with our Scotch tape. And this is the little thing I use for so many different things. It's a spatula, and it doesn't actually have any sharp ends on it, so it's round the whole way around. That's what I use for skin scrapings. I don't use scalpels, and I also use that to collect cytology. And it's so much better to me than using a scalpel, because if you have a dog that's jumping around on the table, or you want to scrape around an eye or on a foot or something like that, there's no way you can cut the dog using that, and it will collect a diagnostic sample for you. Now, if you want one of those, you're probably going to have to email me directly. I do have the link coming up here, but to get them into Australia seems almost impossible. And even for me, to get them into California when I was living there, I had to do a background check and provide my bank account details, because in California that was considered a weapon. And so I ordered a bunch of them when I ordered them, so I didn't have to go through that process again. And I think they were like $4. So if you want one, I'll be happy to send one your way. Just send me an email and I'll post one out to you. But that's the link there if you do want to try and go through the rigmarole. And then these are some of the organisms that I collected. So the one in the top left I collected using my spatula, and the one down the bottom I collected using tape. So tape can be more frustrating to look at. I like to see images being beautiful and clear, but tape does have its place. It just takes a while to get used to looking at the images. Lovely neck there with malassezia, and that's a before and after picture there after treatment, and that one was just treated with topical therapy. So I like to do a lot of things topically, and a lot of the things are human products, but you can carry them in your clinics. And there's a really good pharmacy called Pharmacy Direct that's just here in Silverwater, and when I was working in Western Australia, we used to order all of our human products from there and have them shipped, so they'll ship to anywhere in Australia. They're probably the cheapest place to get the human medications, and for a neck like that I would use Canesten cream, so 1% clotrimazole once a day, and that'll usually clear it up very nicely. So we went through the history and clinical signs before. And as I said, the intradermal testing and serology testing are only if you want to do desensitization. Otherwise, it's an academic exercise. When you're doing the serology, I recommend using HESCA or the test that Vetnostic/Gribbles runs. I did have another test that I submitted to IDEX that wasn't the HESCA test, and I actually submitted about 10 to them. The results always came back completely flatlined, so I don't have any idea what sort of test they're running, but I was getting really good skin tests on these patients and absolutely nothing on my blood test, and so I haven't used that test since, but I've been pretty happy with the Gribbles one that I've been sending them to. So now we're going to talk a little bit about the skin barrier. And so the skin barrier is affected not only in atopic dermatitis, but also in conditions like pemphigus or ichthyosis. And when we're talking about the skin barrier, I'm really sorry, my pointer's not working, so I have to use my arms. We're talking about this layer up here, which is the stratum corneum. And so the defect in the skin barrier seems to be an abnormality in that lipid layer. So that's the lipids that form between the corneocytes or keratinocytes. And there seems to be a decrease in a protein called filaggrin. And in humans, they actually test for this mutation in the filaggrin gene. And if there is a mutation in that gene, they can predict that that person is likely to develop atopic dermatitis. And what happens when we have that mutation and an abnormality in the lipid layer, skip to the next slide. So this is the normal skin, and I explain this to clients when they're in an appointment with me. I say it's like a brick and mortar. You've got the bricks, which are the keratinocytes, and then the mortar, which is the lipid layer between those keratinocytes. And then in atopic dermatitis, it looks a little bit more like this. So you've got these big gaps between the keratinocytes, and that allows water to evaporate, and that's called transepidermal water loss. And it also allows allergens to penetrate. And when those allergens are able to penetrate, they bind to the cells of the immune system and allow sensitization. So this is the diagram of that happening. So we've got the intact epithelial barrier. These APCs are the Langerhans cells that I mentioned before. And then we've got the damaged barrier. So the Langerhans cells are binding to the allergens, initiating the immune response. This is an electron micrograph of the stratum corneum of a dog. And you can see we've got our keratinocyte on the left there. And then what's highlighted in the red is the lipid lamella or the lipid layer. And you can see in the top right picture that everything looks very homogeneous and smooth. But then we skip to a dog that has atopic dermatitis and it's all over the shop. There's clearly a defect in the lipid layer in these dogs. So there's a dermatologist in the US called Rosanna Marcella, and she's very big into the skin barrier and has done quite a bit of research in the field. In humans, what they've shown is that if they can pick up this mutation in filaggrin in a baby, and they know that that baby is likely to develop atopic dermatitis, if they start to smother that kid in emollients, usually petrolatum-based ones, then they are much less likely to develop atopic dermatitis later in life. And that is because the allergens are not being allowed to penetrate because we formed a barrier in that area. And then in dogs, we have done a few studies where we're applying products to try and correct the skin barrier. And there are lots of different products that all contain very similar ingredients. And ceramides, free fatty acids and cholesterol are all components of that lipid layer of the stratum corneum. I see Tanya standing up the back there. She's like, hurry up. And so if we apply these products topically, ultrastructurally, we did get improvement in the lipid layer. And clinically, there was also a decrease in pruritus. So these products definitely have a role. And I use them very frequently in dogs with atopic dermatitis. Dermacent is one that we have here in Australia too. And in the study that was done in Dermacent in Germany, they also did show a decrease in pruritus in patients where that was applied. Oral administration of fatty acids, that did show an improvement ultrastructurally, but not clinically. There wasn't a significant clinical benefit. I do use fatty acids in dogs, but I don't use any of the veterinary products. I think you have to give too much of it to achieve an effective dose. If you're dosing fatty acids, so fish oil, which is omega-3, I'd usually dose that at 1,000 milligrams per 5 kilograms. You just need to make sure there's no added vitamin A or D to those products because we could potentially cause toxicity in a larger dog when we're giving lots of fatty acids. So now on to management of the extremely itchy atopic dog. And when I explain pruritus to clients, I go over a threshold phenomenon, and I'll just show you the diagram. So every dog has a pruritic threshold. The dog may have atopic dermatitis, but when it's just got atopic dermatitis, clinically, it's not too bad at all. But then it develops a food allergy, and suddenly it's pushed over that pruritic threshold. On top of its food allergy, it now gets an infection. and then it gets fleas. So now it's extremely pruritic. And the reason I use this diagram is because sometimes it's difficult for a client to understand exactly why I'm trying to manage so many things at the same time, and this makes it a little bit easier for them. If I put them on flea preventative and take away the fleas, the pruritus goes down. I treat the secondary infections, the pruritus goes down. I treat the food allergy and they're comfortable, and maybe I don't need to do anything about the atopic dermatitis. So as far as how we manage atopic patients, usually it's a combination of all sorts of things. So topical therapy is probably the thing I try and use, and the good thing about topical therapy is that we're directly delivering the drug to the skin. What I use the most of topically is topical steroids. So there are two main ones that I use. Cortivance, which is really great because it's not absorbed systemically. The only thing is with Cortivance, it does have an alcohol base, so if the skin's quite irritated, a lot of dogs are going to resent the application. So in those cases, I'll use 0.1% mometasone or Elicon cream, which is also a human product that you can order from whichever pharmacy you choose. And these feet are beautiful candidates for topical therapy. The disadvantage of topical therapy is definitely owner compliance. There is the potential for irritation, and the most common thing that I see contact dermatitis or irritant dermatitis with is Neocort. I don't use Neocort at all. Neocort contains neomycin. That's the drug that we most commonly associate cutaneous adverse drug reactions with. I think there's better products out there. If you want an antimicrobial, use Bactroban, which is mupirocin. If you want a steroid, use mometasone, use Cortivance. And then if you want both at the same time, use a combination of those products. This is a dog that had too much steroid put on, and those are the biggest comedones you're ever going to see, as well as skin thinning and atrophy there. So we do need to be a little cautious when instructing clients about how much to put on. Facial folds of bulldogs are really good areas for topical therapy. And then bathing is also really effective, and you probably get asked by your clients fairly commonly, how often should I bathe my dog? Well, the studies say weekly is probably a good interval to bathe your dog, because bathing the dog weekly removes allergens, removes scale, and decreases the normal amounts of bacteria on the skin. And what we generally recommend bathing with is using something mild and that doesn't strip the oil, like Episoothe would be perfect. And then tacrolimus, you do need to get this compounded. We don't have the brand name form Protopic in Australia, so Bova will compound that for you. And I use that quite frequently in atopic dogs that have pruritic feet that haven't responded to my topical steroids. Tacrolimus, think of it as like a topical cyclosporin, same family of drugs. It tends to be extremely well tolerated, but it can sting on application, so some dogs will really resent the application of it. Cyclosporin, I have a love-hate relationship with this drug. I think we use too much of it in the veterinary profession. In dogs, if we're dosing it, we dose it at 5 mg per kg. Cats is slightly higher. When we had ketoconazole, you can combine that with Atopica to get away with a lower dose of Atopica, but now that we don't really have ketoconazole, that's a bit of a moot point. Cyclosporin side effects, vomiting and diarrhea are the most common thing that we see with cyclosporin. For whatever reason, if you keep the capsules in the freezer, we seem to avoid that. So I usually recommend to all my clients that the capsules are stored in the freezer. I also recommend to give it with food. It doesn't affect the efficacy and it tends to cause less vomiting and diarrhea. Papillomas I see pretty commonly, hypertrichosis or excess hair growth pretty commonly too. Renal and hepatic disease, I've never seen it, but it's been reported. And then gingival enlargement. So this is some dogs with some hair where it shouldn't be. Gingival hyperplasia. I don't recommend the azithromycin. I've tried it 10 million times and it's never done anything. The only thing that's going to fix that dog is either stopping or reducing the cyclosporin or surgical resection. And then papillomas on the nose. And then a little papilloma in the medial canthus. As far as cats with cyclosporin goes, I'm really cautious in cats. I've killed 3 cats on cyclosporin. They got toxoplasmosis and died. And so now my protocol for using cyclosporin in cats is I'll do a toxoplasma titer, so an IgG and an IgM before I start them on cyclosporin. If they have a positive IgM, that indicates an active infection. That cat's not getting cyclosporin. If they have a positive IgG and a negative IgM, that indicates previous exposure. That's actually the safest category for that cat to be in. There have been no reported deaths in cats in that category. If the cat has a negative IgG, negative IgM, no previous exposure, no active infection, that's a really high risk category, and that's where all my cats have died, in that category before. And so how do we prevent them from developing toxoplasma while on cyclosporin? Make sure they're not allowed outside, and they're not allowed to be fed any raw meats whatsoever. Everything must be thoroughly cooked. And I also discuss the signs of toxoplasmosis with my clients, so if they do notice anything, they'll let me know straight away. And then we've got some excess hair growth from the feet there too. So when to use Atopica, I use it in patients that I'm trying to skin test, because I can skin or blood test them while they're on Atopica, or if I'm needing to use massive amounts of steroids to keep them comfortable, then I need to look at switching to a different drug. Or if I have a diabetic patient or a Cushingoid patient, any of those patients would be good candidates for Atopica. This drug here, Apoquel, is a new drug that was meant to be released in Australia this year, but it was released in the US and it was so successful that they now have manufacturing issues, so it's not available even in the US at the moment, unless you're a dermatologist, and so I don't think it'll be available in Australia until 2016. There is a really good video that goes along with this that we won't have time to play, but I'm happy to send that to you guys as well. And essentially how this drug works is it blocks the sensation of itch being transmitted to the brain. So it's very sophisticated with how it works. There doesn't seem to be any long-term side effects with it. We've been using it for about 2.5 years and it seems to be very well tolerated overall. I'm probably the dermatologist in Australia with the most experience with it. I had over 300 patients on it in the US. And when it first came out, I got really stressed that I'd have to do another residency because it works really well. And it's cheap. So for instance, in the US, which is obviously cheaper than here, to have a dog on Atopica, if they say a 30 kilogram dog, it was maybe about $200 a month. This drug, $30 a month. And how they price it is they price it that no matter which strength tablet you get, it's all the same cost. So Great Dane versus Chihuahua are going to be charged the same. And so I won't show you the video, but initially when you dose it, it's dosed twice a day. And then after 2 weeks, it goes down to every 24 hours. If you continue twice daily dosing, it will cause bone marrow suppression. Once you drop it down to once a day, doesn't seem to do that at all. Some patients in the study did develop neoplasia, Dermatitis, and then puppies under 12 months developed a fatal pneumonia. So in those cases, it's not recommended to use it. And they say it's okay to skin test dogs on this drug, but I've skin tested a lot of dogs on this drug, and to me, it's looked like a skin test of a dog that's on steroids. And so I try not to skin test them when they're on that drug now. I'd rather use cyclosporin in preference. And so that's a drug you'll be hearing a lot more about. And some of your clients already know about it, because some clients come in to me, and I think they are hoping that I have access to this drug already, which we don't have in Australia at the moment. What I will say about this drug is it's not a drug that I think that we should dispense just randomly to every atopic patient. I think it's another tool in our toolbox. I still do think desensitization, allergy testing are the best route to go, but I think this drug definitely has its place. As opposed to using steroids, it doesn't cause the PUPD, it doesn't cause the polyphagia, so all the things that clients hate about steroids, this drug won't cause. And in contrast to cyclosporin, I think this drug is much more specific with which aspects of the immune system it's suppressing. So I think to say a drug is safe, I hate to do it, but I think it's probably safer overall than using Atopica in our patients, which is why Novartis didn't sponsor me for a talk. And then corticosteroids in dogs, I love them, I use them all the time. If I had a choice of which product to use to reduce pruritic in my dog, Atopica versus corticosteroids, I'd use corticosteroids any day. We've been using them for years, we know the side effects of them, they're predictable, they're very safe. We just need to make sure we use the minimum effective dose, so whatever the minimum amount is that keeps the patient comfortable. And in cats, we need to remember to use a slightly higher dose. And then antihistamines, you won't really see me prescribing them. Maybe in the atopic dogs that you get, they work, but none of the ones that I see, they tend to do anything in. If you are going to prescribe antihistamines, the ones that have been shown to be effective in studies are hydroxyzine, cetirizine, and chlorpheniramine. And cetirizine is Zyrtec. And in cats, the doses are slightly different. And then as far as the desensitization goes, this is a skin test here, and typically they won't have quite so many positive reactions, but they certainly can. Cat skin test, and cat skin tests are so frustrating for me to do. No matter how much Domitor I'd give these guys, they're still moving around on the table. I'm up to 20 micrograms per kilogram, which freaks a lot of people out, but that just seems to be enough to keep them still for 5 minutes. And then the most common allergens that we see are house dust mites. In Sydney, there's certainly a lot of pollens that are testing positive. Lamb's tongue and sweet vernal seems to be really positive, and I'm getting a lot of positives to arthropods as well. And then when I say to clients, when clients ask me how effective it is, I say it'll work in about 70% of patients. And so when I say it works, I don't give them false hope. In that 70% of them are not going to be so perfect that they require no other therapy. By far, the majority of that 70% are going to be much improved, but they still require some medication. So for example, if a patient was receiving Atopic or prednisolone daily, and after the desensitization, they only required it once or twice a week, that's still a success because they're on a lot less medication than they were on previously. And then the injections are usually the way we administer the desensitization, but there is an oral formula called sublingual immunotherapy, which I think is a silly name because no dog is going to sit still enough for you to get this stuff sublingually. It's oral. It's getting somewhere in the mouth. And the studies have shown that it seems to work just as effectively as the injections, but it is harder work because the injections, once you get to the maintenance, is every 3 weeks, versus the oral formulation, which you have to do twice a day ongoing, and the dog can't eat for 15 minutes before or after you administer it, so it's quite a lot of work to do that one. And then in cats, they probably respond a little bit better than dogs to the desensitization. So in summary, atopic dermatitis is really complex and we need to use a variety of different treatments to manage our patients, and sometimes it can take a little while to get the recipe right, and not every patient is going to be exactly the same. If you guys think of any questions, you're more than welcome to email me. I am on a plane to London tomorrow, but I will still be checking my emails. So if you want any spatulas or anything like that, let me know. Happy to get those sent out to you.